All right. Thank you very much, Natasha, for inviting me. And it's been a challenging area for us. So I kind of wanted to look this thing in depth. And then I said, oh my God, what did I sign up for myself for? The HIV drugs. So I just have like kudos to all of you who do this, because it took me a while to orient myself to just all the codes. And I had to like call a few friends for help. So anyways, let's get started. And and then just a little bit putting things in context. You guys probably know more than I do, and that, you know, about the HIV drugs. So it's more like setting myself for like orienting myself. So today we will just see like what are the factors impacting weight changes in persons with HIV, and why is that important, right? Because obviously to reach any goals, we have to identify what are our barriers, and so that would help us like help our patients best if we know what are the factors that are impacting and how much do we really know about those factors. And then we will review available treatment options. And as you know, there are like no guidelines that's per se specifically for persons with HIV, but you know, we can see what we know currently, and then how it would apply to patients without you know, causing any harm, and understanding how to counsel them. I think that is something we all feel we didn't get much training in medical school or residency, and so how can we do that? So what the literature suggests, you know, there are 3 or 4 main categories like HIV characteristics, and that's not you know, makes a lot of sense. Obviously, if the disease is severe, then the starting weight is less, and then obviously it would take you would see more weight gain, so net change is more prominent. And then if they have any history of drug use, obviously their affects you know, how they contracted is also different. And then we see more pronounced weight gain in females, and especially Black females. And then in the categories that we see more weight gain with integrase strand transfer inhibitors as compared to the non-nucleosides or the protease inhibitors. And this is a very simplified version of like what the data tells us. And as you know, these drugs do not stand in isolation. They come in combinations, and it depends how the trial is conducted, which is the backbone drug, and what are the other drugs used with it in combination. But anyways, just to understand the magnitude, like over 2 years, some of the drugs do stand out in each category. So they all cause to some degree weight gain, with the exception of 1 or 2. But then what are like from among them, which are kind of do less of the harm regarding the weight. And then the ones you see in each category in INSTIs and NRTI and NRTI, like all these drugs that have that they do cause more than 10%. So on average, we may not see. So when they pool the data together, the older trials, obviously patients were not gaining that amount. Of the newer trials, which have more INSTIs in it, they obviously show more weight gain. So overall, it doesn't. But then some patients obviously are more at risk. So the recent meta-analysis that is referenced here. So one third of the patients gained more than 5% weight, right? And then 1/5 gained more than 10%, and then they said 30% lost weight also. So obviously there's this mix, and how do you approach? There is like not a straight answer. So so obviously how, and you know, in clinical practice, how you see that would also affect that. And then is it the weight gain alone, or is it the weight gain can cause some cardiovascular risk factors, or is the cardiovascular risk factor comes in you know, independent of it? And then again, some data indicate that even within 4 weeks of starting some drugs, and this is obviously not all drugs cause it, it's just all the combination that we see with different drugs, that we see so some of the drugs do cause some like increase in insulin resistance and fasting glucose within 4 weeks, right? And then the risk of diabetes increases and the risk of cardiovascular disease, and that's from the advanced trial. So this is some of the information that we have. But then again, going back to how, right? How did how did we get here? And I still remember been interacting with these issues for like long enough. Back in when I started practice, like around 6, 7, 8 years ago, we would have shared patients with you guys, and they will say, and one of the things we do look what drugs they're on. And I personally, I have asked many patients, like, what does your HIV doc think about your this drug? And they say, no, there is no weight gain. So it did took us a while to increase to realize like how much, and again, it's not like one size fits all. So this is something. So the next, I wanted to ask you guys, what did you, in your experience, like, what did you guys think of causes, like mechanism? I know we know like in our literature and weight management literature and obesity medicine literature, lipodystrophy is the only thing that's mentioned, unfortunately. And I know that's associated with protease inhibitor more than any other drugs. But I just wanted to ask you guys, what do you guys understand? Like, if you guys want to type in the chat box, because obviously there is a lot of debate about it, like what is causing this weight gain? Because for years there was a lot of muscle wasting and losing weight, and now we are on the other end of the spectrum, that we have this this issue. So anybody has any thoughts about this? Right. So what I could gather from the data is that, if, and there are several, right? So lipodystrophy, as I mentioned, some mention of return to health, but then you would ask the question, like, if they return to health, shouldn't they would stop, right? At some point, body should reach in homeostasis, and they should not go beyond that. And then obviously one set of drugs, also the second generation NSTs have better GI tolerance. And that is definitely a very important factor for patients, right? I had actually yesterday had a patient in clinic who had gained weight back after sleeve gastrectomy, and I asked her what did she think about whether one of the factors could be her HIV medication, and her first response was, it's just one pill I have to take, and that is all, and it doesn't bother my stomach. So immune, so that is obviously is part of it. So return to health, what is and that's also like claused that, if the immune system kind of gets the more of the energy was consumed before, and then once it stabilizes. But then we also see in some trials, when we make that switch, like when patients CD4 count and all of that is stable, then they continue to sometimes gain weight. So, so again, it's a mixed bag, if there is, and then, if it is a healthy weight gain, like they want needed to, and that's, to some degree that is needed. And then melanocyte stimulation, again, these are different drugs, different interactions have been, different mechanisms have been mentioned. So this is, and then, but then how much do we really know? Not a whole lot, right? And what are the implications on health and comorbidities, right? So what are the long-term implications? And then really, if I take my patients off of those drugs, would the weight will go away? And as I said, the switch is not always that easy, right? So patient has been stable on one medication for a while, then do you really want to mess things up with them, or like their tolerability? And I know, other factors, definitely liver and kidney and all of that needs to be, and then their mental health. So there's like too many balls to juggle at one time. So this is just a very, very brief and very simplified version of like what we see from regarding weight in patients with persons with HIV. And then let's switch gears, like what is our approach of weight management, and I hope towards the end I can bring these two together. And and as I understand, most of you do end up being their primary care providers as well. So this does become more pertinent. That how do they address their weight? So on our side of things, American Heart Association, ACC, the Obesity Task, the Obesity Society Task, and they have put out guidelines. They're coming up with new ones now. So these are from 2013, that you evaluate and treat based on BMI and cardiovascular risk. That's simple enough, right? But then really, but when we get into the weeds, what is it that needs to be done? So, but then go according to their BMI and cardiovascular disease, your intervention will depend on that, and your goals will depend on that, right? But understanding that even patients, when they lose 3 to 5%, we see improvement in their glucose, their triglycerides, and then we halt the development of diabetes from pre-diabetes. And then similarly, even more blood weight loss of 5 to 10%. So in a 200-pound patients, if they even lose 10 to 20 pounds, we can see all of this benefits of, reduced need of meds and all of that. So that is the framework. And other things that are important for the primary care is when we are interacting with patients, that we know that from studies that the patients have more success if they discuss this with their patients, with their doctors. And especially when they are not felt judged. So providing more of a sensitive care, and even if you are not ready to integrate weight management into your practice, there is still a role for physician to provide weight sensitive care, and that is we can all do a little bit better about that. And it could be as simple as having having our armless chairs in our waiting rooms and in our exam rooms, right? So a lot of times what happens is patients is sitting behind us, right? And while we're in the computer, right, on my desk, because they can't sit on the chair next to us, they won't fit into it. So they end up sitting on the table behind us. So just like little things that helps us develop rapport with our patients, and then and they do better that way. And then the data suggests that physicians are a frequent source of stigma. And again, it causes less engagement, more doctor shopping. And obviously in patients with HIV, that's even worse, right? Adherence is issue. But then, okay, so we got that far, but what exactly do I do with my patients, right? So counseling strategy, right? So that is again, sometimes we think just imparting knowledge on patient would help them change. It's really, we know this now that it doesn't, right? So it is really step by step helping them change their behavior. And for that, we have to understand where patients are, right? So the 5A model, we assess, and now it's 6A, because we used to have 2 different 5As, now we have combined those. So again, really more or less the same, assessing obviously the risk factors, their BMI, and then asking them, what do they know? Because a lot of times patients do not, it is surprising. They do not connect dots that what is affecting their weight and what is not. And a lot of people think they know about nutrition, but then they don't. One of my patients, she's in her 70s, and she says, all my life I was told orange juice was healthy, and all my family, and obviously she has great grandkids. She says all of our family sit down and we just gulp down orange juice, like thinking it's healthy. And And, just the sugar part of it, like added. So just little things, right? So asking what do they understand, and then it all doesn't need to be, and then you say, okay, I have 10,000 things I want to do with my patient. When do I have time to do this, right? So again, so seeing what you can do, right? A little bit in each visit would help. And then motivational interviewing as another technique, which obviously has been used in substance abuse and smoking cessation, where we understand patients' perspective and see where they are. And then it is really helping patient make their own choice and slowly move towards a healthier goal. And, and so, 5 A's or 6 A's kind of give us the whole kind of spectrum, like the whole like stepwise approach. And then it's motivational. It was like every time how I'm going to interact with my patient, right? And then you advise, and either you assist them themselves or arrange for them, like some help for them, given like what kind of help would be needed to them. And that is something we will talk in a bit, in a couple of slides down. So then again, even if you do not have time to do all of this in your practice, and we know in primary care practice, again, and in another specialties are hard, I think it's just helpful to know what is needed for my patient to be successful, right? Because I see a lot of referrals to nutrition, and some and it's not that physicians are not, they are trying to help their patients, but what is it needed, right? So having that as we, having a lifestyle, again, it's the behavioral change, right? So how do I bring that change? And if there are any resources that my patients can use, either I do it myself or I find some resources for them, right? So two components, right, in nutrition: what to eat and how much to eat. And if you look from online discussions and other things, you would think that we are still stuck in like which diet is better, low carb and this and that. And a lot of time people are consumed in that. But the studies do show us that it's the adherence that is more important. So if patient is eating healthy, but it is something that they can adhere to for what I tell my patients, rest of your life. And then how do we get to them to that point, right? So how do we get to them to eating less and to adhere to something, that they're not used to, right? So this is the journey that you have to take with your patient, that how do you help them find what do they like? And then obviously other barriers that do come in is like, what are their cooking skills, and what are how their other comorbidities are managed and all of that. But then in nutrition, obviously, over time, we've seen the low fat, low carb meal replacement. Patients do end up losing kind of the same amount of weight after 2 years, because some weight regain does happen. But then the most patients who lost most weight, they reported to be more adherent to it. And that doesn't seem like really, that seems very logical, right? And then for women, like 1,200 to 1,500 calories. So average American consumes 2,200 to 2,400 calories. In our practice, we see definitely more when we have them log. But then again, you're asking them to cut that in half, right? And how do we get there? And that is something, part of the behavioral intervention. And we have to, like, how do we create that calorie deficit? So it's the quality and quantity that both matter. And then the third factor is physical activity. And then I think the key point from this is that a lot of times patients are told, or they kind of put this on themselves, that, I should just walk more to lose weight. And, we know that exercise alone cannot help a lot with weight loss. We see more of its role in maintaining the weight loss. But that's, again, is a higher, like 200 to 300. That's like almost 50, 60 minutes a day, every day of the week, like day 6 days a week. But then again, it's not like we have to not address it, but understand what are we going to get out of it, right? It's not like we do not discouraging patients from moving, but again, because otherwise, patients and ourselves, we kind of run into frustration that how come they're not losing weight. And then again, how do we implement all of this, right? The dietary changes and, the physical activity changes, patient never moved in their life, like they just don't, they have a sedentary lifestyle, they just sit and have a sitting job at work, they're sitting in front of the computer like most of us we do. And then, so how do you do that? So again, that is where the behavioral strategies come in. And then, there are structured curriculum of behavior change education. Self-monitoring helps, right? It creates accountability. It creates self-education. Patients thinks a lot of time they would tell you, oh, I don't eat much. And then the next month when you tell them, okay, well, why don't you try logging this month? And they say, oh my God, I didn't realize I was eating this much. So this is kind of like becoming more mindful about them. What are they doing? Meal planning and portion control. So meal planning, people think that, okay, just give me a meal plan and I'll follow it. And that's kind of like a little bit a skewed understanding of it. It is really, you have to be ready. You need to know what I'm eating for the rest of the week. So I'm not really, falling on, stopping at like drive-through or stuff like that. And I'm not, obviously we don't tell them they can never ever eat out, but, less frequently. Having plan, making sure you have groceries, you know exactly what you're doing for at least a week at a time. And then portion control comes in, and then getting to set your goals, right? What is my goal for next month? What I'm trying to eat is, and then setting like achievable, tangible goals, and then a lot of problem solving. There's that is sometimes simple things that, because many patients would say like, there is no time. There is no, for all of this, because it seems overwhelming. So how do you help them, make it easy for them so if they can incorporate that into their lifestyle? And then obviously giving them regular feedback. So if we're seeing them every 4 or 5 months and then, asking, the study shows that doesn't really work. And if we want to really help them, then the recommendations is that all of this is, so at least for 6 months, they would need to be in a high intensity comprehensive lifestyle intervention. And that means at least 14 sessions in 6 months where they are get all of this training. And it can be in group setting, it can be in individual setting. And you would ask, okay, where are these right programs? And I'll get to that in a minute. But then this is again, understand. And sometimes we think that the patients are not doing what we are telling them, but again, understanding that this is what would be needed. This is what is gonna make them, have some success. Another factor that may impact their weight is what medications they are on, right? So, and you can see in the obesity, HIV meds haven't made the list yet. The other stuff that we do add that now, but again, scanning through their medications at the time of starting medication or at any point, that what are the medications, and this is and if there is any plausible alternate, can we do that, right? So not only some of the HIV meds, which we do not obviously, and then we work with our psychiatrist, if there are any antipsychotics, right? If there is an alternate or not, and then we can put them on some medications that will offset. But then again, realizing what are the barriers, right? So trying not to choose that medication as the first go. And the reference here, I'm sure we'll have access to slides, would give you like a whole table of like the drugs that do cause weight gain, and there are alternates for that. So that is, I think, sometimes it's easily switched, and sometimes obviously you have to figure out. But again, I understand, because it's easier said than done sometimes. Sometimes patients need to go on steroids. Sometimes their anxiety or depression is only controlled by the medication that is causing weight gain. So how do we navigate that? So bringing their calories down, again, as I said before, patients are taking at least double the amount of what is required for them. So slowly, again, setting small goals, but Sometimes we use the medications to help them come to a lower goal. And we know from studies that their adherence to any plan improves when we put them on medication. And obviously, because they are able to, right? Because if I put somebody on 1,500 calorie meals, and then they're just starving, how can they adhere to it, right? That's just not, humanly possible. But if they have a little bit of, aid where it will help them to meet that calorie goal, then definitely it would improve behavior change. And that is how we progress. Again, it is approved for BMI over 30 or 27 with obesity related conditions. Again, not many people are trained in using these medications, but again, I think it's important to know what would help my patient lose weight, right? So some of the short-term medications, phentermine is still the more than 90% prescriptions for weight management are written on phentermine. And though it is approved by FDA, and it's more of a historical context, that why it is approved for, it was approved back in 1960s when we thought that we only need to get patients started on weight loss, and it's not. And I have all the medications after 2012 that are approved for chronic use. But anyways, so we do, so that is for 3 months or so, but we do end up leaving patient it on longer, because one of our guidelines do suggest that if it works for the patient and the physician has experience with the drug, then they can make a shared decision to continue that. But then because they're symptomatics, they cause some insomnia, tachycardia, increased blood pressure. So like any medications, they have their own set of side effects. And so these are the short-term, as I said, phentermine is the most common. The other ones, rarely do we get to use them because of and then if the ones are not available, and usually patients end up losing 3 to 3.5 kg, so almost 8 to 9 pounds on these, and some do lose more than that. And then this the list for long term, and it always makes me happy when the list keeps getting longer. We recently, a few weeks ago, we had additional of semaglutide weekly injections to that, and as you can see that in the whole list, that can cause most of the weight loss or most weight loss. And then so orlistat, obviously that's a lipase effect locally in the GI area, in the stomach, in the intestine, reducing the absorption of fat. So the side effects kind of are like that, the diarrhea, flatulence, but it is kind of mostly in a week or so patients to get over that. Then a combination of phentermine and topiramate is approved for long-term use, and we've seen good results with that. And then, but we need to make sure patients are on effective birth control. It does cause some altered taste, which can sometimes actually work in benefit. The patient will lose taste of the sweets sometimes, and sometimes for the carbonated drinks. And then naloxone and bupropion, and then some patients who are already on Wellbutrin, then we can just add that. And then Victoza, it comes as like liraglutide, that comes with Victoza and Saxenda. And then Saxenda is the higher dose one, 3 milligrams, and both liraglutide and semaglutide are also approved for diabetes, but at a lower dose. So sometimes if insurance gives us trouble, we just keep them on a lower dose. And as you can see, the corresponding weight loss with these. But the weight gain reoccurs once the patient goes off of these medications. So again, a lot of patients do ask this: do I have to stay on it for long term? So we do see weight regain within 3 months if patients get off of it. One of the newer, it is approved a device, but it is taken by mouth. It's a super absorbent hydrogel. So it's 3 capsules patient takes before lunch and dinner, and then it kind of swells up in the stomach, and it helps patient. And it was approved, I think, last year. Yeah, and then it became available in the market this year. Again, if we do not have any systemic side effects, we want to avoid them, then this is a neat option. Then we have minimally invasive procedures. V-block fallen out of a lot of favor. here. Then we have intragastric balloons, Spiroset and Oblong, but in HIV, patients with HIV, I think absorption may be an issue. Obviously, we do not have any studies. And these are limited procedures as they are FDA approved, but insurance still don't pay for it. So we have, but then we understand the mechanism of it. So I think it seems like it may cause some absorption issues if with the HIV medications. And then bariatric surgery, right? So for patients over the BMI of 40 and BMI of 35, then obesity and had obesity related comorbidities, then we can have, and that is the most effective thing, the tool we have, right? But again, nothing is magic, you know, if everything patient has to work on behavior change, because obviously weight regain after the surgery is also real. And if we haven't invested enough time then to prepare for the life after surgery, then it can be an issue. And then again, in patients with HIV, changes in absorption of ART and Roux-en-Y should be considered. And then other thing we see in patients with bariatric surgery, long-term issues with protein malnutrition. So if we are concerned about that or not, so that is something we also need to, so every approach we take, we just need to make sure that's appropriate for patients with HIV taking drugs. So again, bringing it all together, what should be like, how should I approach it in my clinic if I was an HIV doctor? So that's kind of like, how do I like optimize my clinical practice, right? So and that is for each individual. They decide what do they want to, how much they're comfortable with, how much time they have, and then how much they have resources in the clinic, right? And really that's an individual, practice. Sometimes practice are supported like that. Sometimes, sometimes it's hard. Sometimes it's really hard. So how can I optimize what things I can implement, and then that the patients can be helped, and then what are the available resources in the community, right? And then if it is appropriate, refer to like a weight management specialist like our clinic. So again, I think there is a role for everybody in it, and it will take a village to help all of this. And then for the for the community resources, TOS, the Obesity Society, recently put this out. Weight Can't Wait, and it's like a 2, 3, I think 7 pages total, and it talks about 5 A's, 6 A's now. And then it also talks about other resources that are in community. Couple that I want to highlight, and you can go through this like the whole document, and it really outlines like what are the resources for primary care providers. That the couple that I wanted to highlight are the commercial weight loss programs. So our group did a systematic review in 2015 that did show that patients on Weight Watchers had more clinical trials, and patients end up losing more than 2.5% of their body weight than control, and similarly patients on Jenny would lose more than 5%. So those are the so those are the plan, and again how they would give patients a structure and education. I think that's again would be helpful. And then the DPP programs, those are group sessions, and they kind of touch on all the behavior interventions with the patients. And there are actually now, since COVID, they've been offered virtually, and out of Brancati Center, we do have, like within Hopkins, that has been offered. Used to be that it would be just offered out of churches, but now it is offered, and the member of that church would go. And we have seen a lot of success. Patients would lose, and that is for patients with pre-diabetes or at risk of diabetes, and the patient would lose 7 to 8%. But they do develop lifetime healthy habits. So again, these can be availability and may vary according to geographic location where people are. But I think combination of all of that to some degree help. And then something, I wanted to suggest, and obviously there is no data in patients with persons with HIV or any drugs, that, we do have some drugs, and again, these are off-label uses. In metformin, there are studies that patients who are on antipsychotic medication, they do lose 7.2 pounds or so on the drug. And then it prevents actually weight gain associated with antipsychotics, because that's another huge field. And if you look at this, how many organs does metformin impact, right? It's not as effective as I would want it to be, but to create more pronounced weight loss. But definitely, this is something that can be considered if another weight promoting medication is HIV medication is being started. And then similarly, topiramate, it's also been used as to offset the weight gaining effect. And then it's a centrally acting, and inhibits the GABAergic neuron uh, to increase appetite suppression, and that is what is thought. We don't know exactly though. And then in some patients, it so up to 3.4 kgs, and then and then one of its sisters, zosinamide, calls up to 7. So these are some encouraging. And then this, even if patients does not lose weight, it can help. It can help with prevention of weight gain. Possibly, again, we don't have any data in persons with HIV, but adding metformin may not. Again, we have to weigh the risks and benefits there, and what are we really comfortable with. So just bringing it all together, if is a treatment naive person with HIV, then I can think about, just talking to patient about the potential side effects, and especially in patients who are at high risk, right? Who are women and black women especially, because they are at more risk. And then if it is possible, and I know they all come in combination and it's easier said than done, but that can be, and we're already thinking, okay, what are the best combinations for making sure less liver, kidney toxicity and all of that. So don't want to really necessarily throw in another factor into decision making. But again, this is, if it is possible, then patient can be offered. And then at the same time, reviewing for other weight promoting medications, right? So not leaving them on a double, problem. And then if the BMI is less than 25, then avoid weight gain, then counseling them, making sure that they continue with their healthy lifestyle. And then if their BMI is more than 25 and has risk factors, then stepwise, right? Counsel on weight status depending on their BMI. If it is BMI over like 20s, more than 20, 25 with risk factors, definitely you can refer them. If it is just no risk factors, then we can continue to counsel them. And then obviously adding medications after BMI 27 with risk factors, or 30 without risk factors, and bariatric surgery comes in at the BMI 40 or 35. So all of these options are there. Again, as we gather more information, we'll have more better ability to make these decisions. And then if it is already done, again, we do not know now, like we know to some degree, not clearly, if it really switching would help or not. But really what patient prefers, what are the risks and benefits. What I see in the literature, obviously the switching is not always as easy because obviously tolerability and all of that factors come. So if possible, switching to less growth promoting, reviewing other, so again, going through the same drill. And then if the BMI is less than 25, then avoid further weight gain, try to maintain that, and then counsel on weight if the BMI is over that, and then utilizing all the tools. So this is all I have. I hope it makes sense. and happy to take any questions.
Thanks, Subia. Sorry, I'm having some internet connectivity issues. Thank you for that wonderful, wonderful review of everything. And I think reminding us of all the medical options available to us as well from a weight management standpoint. Does anyone have any questions that they were hoping to ask Dr. Chaudhry about any of their patients or management plans?
I think that was wonderful. Thank you so much. And I love that you put all of this in one slide deck that we can use to refer to in the future. I appreciate that. I'm curious, you mentioned referral to an obesity clinic. Is that something that's offered here, and how do we do that?
Yeah. So that's our clinic. It's Eating Healthful. It's a mouthful name. We just opened doors. I think we were supposed to open last year. We're out of Green Spring, Healthful Eating and Activity Center. The referral can be made in Epic. It's under internal medicine. And I'll see if I can put the link.
I think if you just put in weight clinic, it'll come up as an option in Epic as you see. There's different options, Kelly, but it should say I think weight management, and then it says internal medicine in parentheses.
Yeah, but it is under the Department of Internal Medicine, and we do have meal replacement as an option. Yes.
And are you commonly prescribing the diabetes medicines that you described in your talk?
Yeah, we prescribe all of them. So all the weight management, depending upon which would work best for the patients. And before that, it really comes, the affordability becomes, a question, because a lot of these medications are still not covered by insurance. They have become more affordable though in last few years. But yeah, so we do use all the medications that are available for weight management.
That was actually a question I had for you, because I have tried to prescribe semaglutide a couple of times, and sometimes it actually seems easier when I have patients with priority partners than some folks with private insurance. Are there any tips or tricks that you've had to get it approved when it's not being approved?
So I think the biggest trick is sometimes it is approved even when they do not have diabetes. If you put in cardiovascular risk factors, I personally didn't have success with that, but sometimes. And then secondly, keeping them on lower dose within the range of diabetes. So semaglutide, for example, the dose goes up to 1 milligram. But and we do not have, like, it was just approved for obesity, so we do not have Wegovy is the brand. Is not available yet, but it is like 2.4 milligram. And same thing with liraglutide, Victoza, if we stay to up to 1.8 milligrams, the insurance kind of bears with it. Above that, they won't. So that's the trick, sometimes.
That's really helpful to know. I didn't realize that the dosing would flag different things within insurance. That's really helpful.
Yeah. Anything else? Any other?
One other question I had to be, so there's also the non-invasive, not non-invasive, but the bariatric options that are not surgery, but are things like endoscopy and whatnot. If we wanted someone to be evaluated for that, can we assume if they come to your clinic that as part of that process, if you all think they're appropriate, they would get referred to either bariatric surgery or the endoscopy clinic for management? Or is that something that we should be thinking about doing as the primary care?
Again, as I said, it is really up to the individual physicians, how much they're comfortable with, how much they think they have resources to inform their patients of risks and benefits. But the minimally invasive done are under the Department of GI. Dr. Kumbari was doing it. I heard just yesterday that he's leaving. So Dr. Badruddin is the one.
Oh, wow. Okay.
Yeah. So, but then there are obviously Dr. Khalud is died. He was doing that. But we still offer these, and then I find the biggest barrier is the money part, because if the insurance isn't covering, then that's a big deterrent for patients. to do that. Yeah. But to the other part of bariatric surgery, most of the insurance do require them following up, like being in a 6 months program for lifestyle intervention. So for that reason, definitely we see, and that can be done like in a way that it doesn't really, you're not really, but I think that time is good time to help patient develop some healthy habits before the surgery. Yeah.
One question is, I know because the clinic has been so popular, you all are very booked up, which is great. Do you anticipate there being more slots opening up in the next year or so?
Yes. We have a new fellow actually starting. We're offering fellowship, so that, and then we have actually one more faculty starting like next month, July. Yeah. So hopefully the templates would open, and then that would definitely ease the backlog. Yeah. So it's a good problem to have, not for patients. So we try our best to accommodate. But then on the other hand, I think at the primary care level, I think one thing that's extremely important is if the patient is ready, because a lot of patients do think that they obviously, if you ask, they want to lose weight, but what does it take? And that as a, like before referral making, and you feel free to email like one of us that, if this patient is appropriate, because a lot of times it's not in their control, right? They are stuck in such a situation, like their comorbidities and all of that. And do we know that losing weight would help their comorbidities, but adhering to a lifestyle plan or a lifestyle intervention does require some amount of stability in one's life. Some amount, right? I'm not saying never it's going to be perfect, right? But for example, if one patient is in and out of like hospital every few months, right? So it would be very hard for them to adhere, right? Because, they're just consumed by whatever, whether it's renal failure or heart failure or, whatever complications, or if their mental health is not stable, right? So I think that is where seeing like how patient is ready. And then if it is like what their understanding is to getting them ready, because yes, you will have to log what you're eating, right? And it's not always app, right? We have patients who do not use apps and stuff like that. So we work with them other ways. So if it is something that you do work with them, right? So I think readiness is important, because, then they would come and they say, oh, really, there's not, it's a lot of work and I just don't have that much time in my life.
Yeah, I think if we think of it the same way we think of our smoking cessation strategies and creating that plan.
Yeah, definitely. Behavior change is hard. It's very hard to have patient move from what they've been used to, like for most of their lives. So you have to find, and then because we don't want to add negative experience, right? Because then say, oh, I tried that and that didn't work, right? And similarly, thing goes with medication. Sometimes people are put on phentermine or other medications, but if it is not combined with lifestyle intervention, oh, I tried phentermine and it didn't work. But then, if we didn't use it, with the lifestyle intervention, then obviously it's not like magic. Right? It would help you to get to a lower calorie goal, but then we have to, as a patients, also have to put some amount, and then they do need that help. And question is always, are we providing that, or are they ready for it or not?
Right. Great. Any other questions? All right. Well, thank you again so much for sharing your expertise with us. And I know this isn't something we've actually talked about in a little bit, and there's been so many updates and changes in what's been available from a medication standpoint. So I think it's been really wonderful to get a nice broad overview. And thank you so much for delving into the HIV related issues as well, which is an extra treat. And I know it's like a chasm of information.
Yeah, it is.
Natasha, this is not a question, but just a comment and a piece of news for the providers sitting in on this call. The AIDS Clinical Trials Group is sponsoring a randomized prospective study for people who have had significant weight gain on integrase inhibitor-based regimens to be randomized to maintain their integrase inhibitor-based regimen or switch to a doravirine-based regimen. It's ACTG study 5391, and we are planning to open that study and offer it here. It is going to open up sometime this summer.
Okay.
So just so everyone is aware, if you have a patient who's gained significant amounts of weight on doravirine or bictegravir and would be interested in a study where they could be randomized to switch to a doravirine-based regimen, this would be a good study for someone like that.
That's great. Do we know what is going to be defined as a significant amount of weight gain? Is there going to be a criteria?
I think it's 10% of
Okay.
over baseline. I think
Natasha, I have the protocol. I can share it with you.
Yeah, that's
just,
great. I can put
if
it in
you-
the teams chat if folks can be aware of it. That's great. I think I have several patients who I would refer to that study. Great.
Thanks.
Okay, great.
Thanks so much for
Thank
the update,
you.
Charlie.
Yeah.
Thanks, everybody. Thank you.
All right, everybody, have a good weekend. Thank you again, Dr. Charlie. This was a fantastic session. Appreciate it.
Bye-bye.